Hello, I'm Nora Hanna, Chief Engagement Officer at Sun Health, and I'd like to welcome you to this episode of Coffee Connections. We created this series to help you stay connected to the latest developments in healthcare and wellness by hearing directly from experts in our community. The Sun Health Foundation is committed to ensuring that this region has access to the most recent medical and technological advancements, and that we attract the brightest and best practitioners for care. To that end, we are the exclusive philanthropic partner to Banner Boswell and Banner Del E. Webb Medical Centers. Our mission is to empower others to live longer, healthier, and more purposeful lives. So we're excited to be able to offer you this unique access to these valuable expert resources. Thank you for joining us and enjoy the presentation.
Everyone in the community to live healthier for longer. And we do that in a variety of different ways. We have a Center for Health and Well-Being that offers free programs to anyone in the community. We have a healthcare navigator. We do a lot of work around diabetes prevention and fitness, and also your social and emotional health. So it's a big part of what we do. We also have a very substantial scholarship program that is focused on healthcare workers. And that is something we are going to continue to need to grow. It's been hugely successful. We're now expanding it to more of the Southwest Valley as well. It's largely been focused on nursing, but it has gone beyond that in its over the many decades that we have had this program. And I think we normally give about $500,000 a year in healthcare scholarships, so it's real. Yeah, it's substantial, and again, it's growing. So we intend to take that even further into what we do. So all of this, again, is around advancing the well-being of everyone in our community, and it's a mission that's very well aligned with the mission of Banner. That really wants to make sure that we're providing the health care to everyone, regardless, and ensuring that everyone stays as healthy as possible. And with that, I'm going to introduce our speaker for today. I'm very interested in so many ways. As I said when I met him, his hobbies are the exact same as mine, so we have so much in common, other than me being an accountant and him being a surgeon. Other than that, everything in common. So Dr. Mehrotra is a board-certified general surgeon dedicated to providing expert, personalized care. And my favorite part about this is his approach emphasizes collaborative decision-making, which I think is finally a trend we're seeing more and more of in healthcare. Thank goodness, because I do think we all have a personal responsibility for our health, which maybe we've abdicated, but also I think the medical community is now moving more towards supporting us in that work. He likes to ensure patients understand their diagnoses and all available treatment options, both operative and non-operative. So even though he's a surgeon, they're trying to give you as many choices as possible. He got his degree from the U of A, yay, go Cats, in 2015, and did his residency at Banner University. So his hobbies, which you're going to want to know, right, because they're the same as mine: sports, fitness, movies, and spending time with family and friends. So with that, I'm going to turn it over to Dr. Mehrotra.
Thank you. Good morning, everyone. Can you hear me? My name is Dr. Mehrotra. I'm a general surgeon here at Banner Del Webb. I'd just like to emphasize a couple things that Nora said. First of all, I didn't know what she had just shared about Sun Health, but in terms of starting Alzheimer's research almost 40 years ago is amazing. And the other point she made, that healthcare is for everyone. I truly believe that healthcare is a right, not a privilege. And I would encourage you all to write to your representatives to make sure that we're not cutting funding to research in healthcare, because that is something that is going on extensively right now, and we're seeing the consequences of that. A little bit about myself, like Nora shared, I graduated from the U of A for med school in 2015 from the Phoenix campus here in town. Did my residency at Banner University, finished in 2021, and I've been here for about 4 years now. So I have no disclosures, no one's paying me to be here. Although if you want to drop a little bit, I won't say no. So today we're going to talk about 4 different things. The goal first is to identify the key stakeholders that provide trauma services here at Del Webb, myself and the team that's involved with that, and we'll show you pictures and who those people are. We'll also highlight the population, the mechanism of injuries, and how our patients are treated from their initial admission here at the hospital and then discharge and follow-up as well. We'll also talk about some of the statistics related to the population that we see here at Banner Del Webb related to trauma. I will go through some of the framework of how we evaluate a trauma patient. I'll try to keep that on a little bit of a superficial level, but if you have more questions regarding in-depth analysis, I'm happy to discuss that with you afterwards. And as Nora indicated, part of what we like to do from a surgical perspective, as much as I like to cut, I think the key learning aspect that comes from experience is learning when not to operate. That's the hardest part of surgery, and we'll talk about some options in terms of trauma where non-operative management is actually in the best interest of the patient. Okay? And then we'll talk about a couple cases, one that is actually very pertinent to our population that was actually from Christmas Eve of just this year, 2025, that I treated. And so we'll talk about that case here at the end as well. So these are our trauma surgeons here today at Del Webb. Dr. Ballesteros has been here since 2015, Dr. Lee since 2010, Dr. Goldfat in 2018, and myself since 2021. Dr. Ballesteros also trained at Banner University when it was still Banner Good Sam. He did his residency there. Dr. Lee trained at Maricopa County, now known as Valley Wise, and then Dr. Goldfat trained in Michigan. And then, like I said, I trained at Banner University. It was Good Sam for 1 year while I was there, so I still like to call it Good Sam. Additionally, we have 4 PAs on our team: April, Kenny, Dara, and Zach. April has been with us since 2018, Kenny has been with us since 2020, and Dara and Zach joined us in 2025. So we have a pretty robust team in terms of who will see you in the hospital if you're admitted as a trauma patient or for general surgery as well. The PAs are critical to our success in terms of being able to help us manage the floor while we're in the operating room. Our PAs will do rounds, they'll write progress notes, they'll see consults, they'll call you back from the office if you call us and you have questions about a surgery, and they manage our post-operative clinic as well. And their favorite part is assisting us in the OR. As surgery PAs, they want to be in the operating room, but they understand that we have other responsibilities as well on the floor. We have 2 nursing staff that are a part of our trauma program. Kelsey is our trauma program manager. She was one of the lead nurses in the ER here at Del Webb for many years before she took over as the program manager in March of this year. And then Sherry is our quality specialist, so she will run our data, make sure that we're meeting appropriate national standards, submit data to the national registry, as well as monitoring our quality improvement projects on the trauma perspective. And of course, we always have to account for our ER physicians, PAs, nurses, certified nursing assistants, lab techs, radiology, and our outside hospital emergency medical services. If they don't bring the patients, how can we treat the trauma patients? So we have to obviously give credit to those. And then obviously we have support from Banner at a corporate level and a system level. Banner has 3 level 1 trauma centers: Banner University, Thunderbird, and Desert, and we'll talk about that here in a second. And throughout the rest of the valley, obviously we have multiple Banner locations, and so it's a really system-wide effort to make sure that we provide appropriate trauma services. So that was our team. Let's talk about the population that we see here. This is going to be pertinent to you all because these are the types of patients that we see, and obviously our population reflects that. So the goal of trauma from a surgical perspective is to expedite the identification of life-threatening injury. These protocols have been in place and algorithms have been in place to ensure that we evaluate the patient in a very specific manner to assess life-threatening issues first and then move on to secondary injuries after that. So from an overview perspective, Banner level 3 trauma centers, Del Webb, Banner Baywood, which is out in Mesa, and then Tucson South is a level 3 trauma center. The closest level 1 trauma center is Banner Thunderbird, and like I said, Banner University as well, and then Banner Desert. And then our sister hospital, Banner Boswell, is a level 4 trauma center. The levels designate the ability and the availability of multiple subspecialties, and that's kind of how that's determined. Being a level 1 trauma center comes in two ways. The first is you can be certified by the American College of Surgeons. Generally, that is one level 1 trauma center in a metro area, and then you can also be certified by the state. So Arizona and Phoenix itself is unique in the sense that we almost have 11 or 12 level 1 trauma centers, but out of those, 3 of them are designated by American College of Surgeons. The remainder are also designated by the state. If you were to go to somewhere like Las Vegas, there's technically only one level 1 trauma center in Las Vegas. Technically, there's only one level 1 trauma center in LA. Technically, in Chicago, there's only one level 1 trauma center because those are certified by ACS. So Phoenix is unique in that sense, is that we have 3. Banner University is a level 1 by ACS. St. Joseph's downtown is a level 1 by American College of Surgeons, and then Valleywise is a level 1 by the American College of Surgeons. Given our location, Banner del Webb, as you guys know, this is where we are. You see the little plus sign there, but our catchment area is almost all of this northwest area, going out to Wickenburg and beyond that to Congress, etc. So we'll get trauma patients from Wickenburg, outside of Wickenburg, that will come to us as a first triage point, and then if they need to be transferred, then we would stabilize them first, transfer them beyond that if it's something that we can handle from a capability standpoint. The American College of Surgeons requires certification every 2 to 3 years. We renewed our certification in February of 2024, so we're good until 2027. That's an arduous, rigorous process that I would not wish on my worst enemy, but luckily we got through it with flying colors. So we were very happy to get that. The only little thing that they told us, unfortunately, is out of our control. It's something at the Banner system level, and so from our perspective, we passed 100%. So we have 2 levels of trauma. Trauma red, that is our highest level of trauma. As the trauma surgeon, I'm required to respond within 30 minutes of the trauma red being called. And so usually if they know that a trauma red is coming in, this is a critically ill patient, either they're coding, meaning that the emergency medical staff is providing CPR to them, putting a breathing tube in, and they are critically ill. And so I have to respond within 30 minutes. The ED provider is at the bedside within 5 minutes, and then the full gamut of available staff in the ER will respond as well to that case. Unfortunately for us here at Del Webb, when we get trauma reds, it's usually a patient who is likely would have expired in the field, and they're bringing them here for us to basically pronounce them. In general, most trauma reds should probably end up at a level 1 trauma center, but we are the closest place to stabilize. So like someone coming from around Wickenburg, getting them down to Thunderbird or even to St. Joe's West is too far of a drive, so they'll come here first. Our second level is a trauma yellow. So for us as a trauma team, we have 12 hours to see that patient. The ED provider and the nurse will see the patient within 15 minutes, and then the EDPAs will also oversee their care. Generally, these are our patients with a isolated orthopedic injury, meaning they potentially maybe had a fall or a car accident, and they have a femur fracture or hip fracture, but they are stable but have a traumatic injury that can be managed in an appropriate time frame. So someone who needs to be seen by a surgeon, needs to be evaluated and potentially operated on, but not someone who is critical to the point that they need to be seen and evaluated within 30 minutes. We also have a pretty robust OB program here, as I'm sure you guys are aware, and there are traumas related to OB patients as well. So say, pregnant patient that is in a car accident, that is considered a trauma. And so we have trauma red and trauma yellow for OB as well. That requires the OB team to evaluate the patient. And in that sense, from our perspective, our goal as the non-OB provider is treat the patient. That's how you treat the baby. That's number one. If you take care of mom, baby will do better. Okay? So let's look at our numbers for 2024. The 2025 numbers, Sherry and Kelsey are working on aggregating now, and hopefully we'll have those next month. But in terms of our total trauma red activations in 2024, we had 16. So you can see that it's pretty rare for us, about 1 1/3 every month or so. Trauma yellow, 1,800. Non-activation, that falls into categories where trauma should have been activated, but it was either under or over triaged. And so we keep track of that as well. That's part of the data that we collect. So we had about 900 cases that were non-activations that probably would have fit into the criteria of at least a trauma yellow. But those patients, they were still evaluated by our service. Obviously, that's how we have the numbers. So let's look at our age range. I think this is pertinent to you guys. 0 to 17, we saw 37 patients. 18 to 74, we saw 789 patients. And then as you can see, a majority of our patients fit in that 74 to 99 age range. And we did have 13 patients over 100 years old that came in as trauma patients last year. So raise your hand if you fit into that 70%. There you go. So this slide shows kind of how we treated those patients in terms of what was their next step once they arrived in the emergency department. About 1,300 patients were admitted, meaning they were at least kept for potentially 24 hours or slightly longer. About 1,100 were discharged from the emergency department, meaning that their injuries were sufficient enough to be evaluated, but there was no intervention required, and they were safe to discharge with close follow-up with their primary care physician. And then about 250 were transferred. And so these are patients that are outside of the scope of a level 3 trauma center, but they had to be evaluated here first to be stabilized, and then were transferred to a higher level of care, meaning they needed some type of intervention that we were not able to provide. So one very simple example is a patient with a head bleed. So say you've fallen, you've hit your head, and you have a bleed. On top of that, I'm sure most of you or some of you are on a blood thinner, whether it's Eliquis, Plavix, aspirin even. That can always make that head bleed worse. And so we don't have neurosurgery capabilities here. So those patients, if they meet appropriate criteria, will be transferred for neurosurgery evaluation. Even if they get transferred, that does not mean that that patient will 100% need a surgery, meaning like a craniotomy to evacuate the blood, but they'll be evaluated where that if they were to worsen in the acute phase, there would be a neurosurgeon available expeditiously to treat them. Okay? So let's look at our statistics in terms of where patients were discharged. We had about 600 patients that were discharged to home. About 450 went to a skilled nursing facility. 192 went to rehab. And so the one thing that sometimes people confuse is what's the difference between a skilled nursing facility and rehab? The way that we look at it from a trauma perspective is, first of all, while you're in the hospital, you're evaluated by physical therapy and occupational therapy. They'll make a recommendation based on your ability to participate in therapy, which location is appropriate for you at discharge. When you're going to rehab, that it's considered inpatient rehab, it's considered intensive therapy, meaning that you need to participate in 3 hours of physical therapy every day. And so ideally for patients that are capable of doing that, that will increase your speed of recovery. When you go to a skilled nursing facility, generally it's an hour of PT every day. So for us, ideally when patients are coming in, say something like a femur fracture, if they are capable and able, we would want them to go to an inpatient rehab if that's the criteria necessary, because that's what's going to give you the most amount of therapy to recover quickly. We did have 7 patients that left AMA, which means against medical advice. So obviously we don't like that. We don't want you to leave against medical advice, but obviously every patient has the ability to make that decision for themselves. We had about 50 patients that went to hospice. In general, we have patients that come in that are already on hospice. So in general, they will get discharged back to hospice. But additionally, we'll have patients that have become, something like a hip fracture where they're too critically ill to go to surgery, or they're having other complications that are medical related, whether it's lung issues, heart issues, kidney issues, to the point that the family makes a decision we don't want to continue to put our patient through so many traumatic events of major operations, dialysis, heart catheterization, and they choose to move the patient to hospice at that point. We do have patients that expire, whether that is traumatic or whether that is post-operatively from a complication. We do have patients that get transferred after admission, meaning they may come in for multiple issues. We can treat 1 or 2 of those things, but then after that we find they have worsening criteria that would be appropriate for transfer. Another example, going back to the head bleed, we can have a patient that can come in, we get initial CT scan, and their head bleed looks to be an appropriate size that it can be managed here, it doesn't need to be transferred. But the criteria, the recommendation is you repeat that CT scan of the head 6 hours after the initial. If that repeat CT scan indicates a worsening head bleed, then that's an indication to transfer the patient for neurosurgery evaluation. So we see that as well. And then we do have patients that get transferred to our psychiatry department as well for their ongoing mental health issues. So other important statistics. These are things that I think apply for you guys. So 85% of our trauma patients that we saw were related to a ground level fall. Who here has had a ground level fall? Okay. Motor vehicle collisions, motorcycle collisions, under triage, over triage. For our motor vehicle collisions, golf carts are included in that statistic. So raise your hand if you have a golf cart. Okay. Now, those of you who raise your hand, keep your hand up if you've had a few drinks while you're driving that golf cart. Okay. Now, of those of you that have had a few drinks, how many of you are on a blood thinner? Yes, okay. We'll come back to that. All right, so now I'm going to kind of go through the framework of how we evaluate a trauma patient. This will be a little bit technical. I'll kind of gloss over some of the deeper stuff, but we'll go through how, when the patient shows up in the emergency department, what the first initial steps are to evaluate them and make sure that you can take care of things that will cause the patient to decompensate quickly, and then hopefully get them to a point where you can stabilize them. So when we evaluate someone from a trauma perspective, it's A, B, C, D, E, and A. A for airway. So the first thing that I will ask a patient when they come in as a trauma patient, can you tell me your name? If a patient can phonate and they can tell you, my name is Bob, that tells you that their airway is patent. They are protecting their own airway. If a patient can't tell you that, then we have to intervene in some way, and that's the number one thing. You have to have your airway open because you need oxygen in your lungs. Oxygen needs to get to the blood, and then when it's in the blood, then it can perfuse your tissues, so that way you get the oxygen you need. Next question, breathing. So inspection, palpation, auscultation. What that means is the patient breathing? Do you see chest rise when they take a big breath in? Do you, when you listen to their lungs, can you hear breath sounds on both sides? If you can't, then we'll intervene, and we'll talk about that next. Circulation, so this is your blood flow. Do they have a pulse in their wrists? Do they have a pulse in their groin? Can you feel a pulse all the way in their feet? That way you know circulation. Blood is getting to the distal extremities, and that circulation is intact, right? Someone has a big femur fracture in their leg, and they have a femoral artery injury on top of that. You're not gonna feel a pulse in the foot of that leg, and so that can tell you that there's a circulation issue. Those are the initial things, A, B, C. Those are the first three things you have to take care of. D, being a disability, this leads to your neurological exam. Can the patient follow instructions? I'll ask a patient, hey, squeeze my hand. Hey, blink your eyes. That tells you, is there a cognitive connection still to the brain? Is the patient following commands to indicate that their neurologic exam is intact? We also calculate something called the GCS, which is the Glasgow Coma Scale. There are 3 different criteria to that. I'll show you a slide in terms of what that indicates, and that's a part of the initial survey as well. All of these 4 things are happening, even 5 exposure, are happening all at once. You got to think of it as a trauma patient is coming in, you have a pit crew, NASCAR pit crew coming in, taking off the clothes, putting on EKG leads, getting an IV, getting oxygen on your nose. You have nurses and techs doing all of that at the same time, while I, as the trauma surgeon or the ED provider, are evaluating airway, breathing, circulation, disability. Exposure is really important because you don't want to miss an injury. So when you're coming into the trauma bay, sometimes we're cutting off your clothes all the way down to your skivvies, right? And that's so that way we can make sure we don't miss an injury. You don't want to find something on a delayed aspect that can lead to a delay of care, can lead to worsening outcomes. The adjuncts that we add on, whether you need a FAST exam, which is what we do at the bedside, it's an ultrasound, and it looks at 4 windows in the abdomen, both kidneys, liver, and bladder, to look for any fluid that may be either bleeding from the liver, bleeding from the spleen, or if you have a bladder injury. That's something we can do at the bedside as the patient is being evaluated, which can indicate a need to go to the operating room emergently right away, even before you get a CT scan. If the patients are stable, then we move to something like x-rays, CT scans, we'll check labs, catheter in the bladder, catheter that goes from the nose to the stomach to pump out any fluid that's building in the stomach. All of this is happening at the same time. So we'll talk about this in a little bit more detail. Airway, is the patient speaking or are they not speaking? Are they protecting their airway? Are they in shock? The GCS calculation, we'll look at that. It's a score from 3 to 15. Anyone at a level of 8 or below generally means that they're not protecting their airway enough to the point that we need to put a breathing tube in. And that breathing tube goes in, they get hooked up to a ventilator. And so we'll show how that score can be calculated in a second. Other things that we can do in terms of trying to figure out whether or not a patient's airways are patent. You give a little bit of chin lift or jaw thrust, then you can lift the tongue off of the back of the mouth, so that way the airway can potentially be open, and they may just be obstructed from their tongue itself. So small things like that. Breathing, this is a little small, but the biggest things here are there are 2 or 3 different types of lung injuries that can be devastating. One is called a hemothorax, which is where the space between the lung and the chest wall fills with blood that can then basically compress the lung on one side or both sides to the point that even no matter how much air we force down into the lung can't expand because the chest is a closed space. So that hemothorax is treated with a tube. We put a tube in the chest to pull out all the blood that allows the lung to expand. A tension pneumothorax can be life-threatening. What that indicates is that you've had some trauma to the chest, the lung has collapsed, and now the space between the lung and the chest wall is full of air. That shifts the heart. If it's on the left side, it'll shift the heart to the right, it'll shift the trachea to the right, and it'll shift the lung tissue to the right. And that can lead to death if it's not noticed immediately. I think we have a picture of that coming up as well. The next thing that applies to you guys, flail chest. So in general, when patients have a ground level fall, and if they land on a side, they can get rib fractures. If you have rib fractures in 2 places in the same rib with 3 ribs that are like that, that's considered a flail chest. That means as you take your breath, you have a paradoxical movement. When we take a big breath in, chest expand, lungs go out. When you have a flail chest, that rib section doesn't respond normally. It actually will go in. That can be an emergency to the point that we have to send you to a thoracic surgeon to have your ribs plated. So that's something that we always look at when patients have rib fractures is, do they have a flail segment? And then an open pneumothorax, that is basically where you have an open wound. So say you have some type of trauma, and then you've also penetrated the chest wall, the muscle, and the lung itself. And so now you have this blowing wound that doesn't allow the lung to expand completely because the air is getting into the chest. And so that's treated with closing part of the wound and putting in a tube. But that can also be life-threatening. Circulation. So this is what we talked about in terms of identifying and knowing that patients are getting oxygen and blood to their tissues. So IV access, making sure you give them fluid. If patients are hemorrhaging, if they're losing blood, the best way to treat that patient is with more blood. Not necessarily saline or anything like that, more blood. Disability. So this is getting to that neurological component that we were talking about. One of the big things that we always have to worry about in trauma is, do the patients have an injury to their cervical spine, right? Because if you have an injury to the bones in the cervical spine, you can have an injury to the spinal cord, especially at the brainstem, and that can lead to devastating injury. So we always want to immobilize the cervical spine when patients come in. You'll see them in that C collar that's very uncomfortable. Have to keep that on, unfortunately, and that helps keep everything in line. So even a rapid twist of the cervical spine when you have a cervical spine injury can lead to paralysis, even to the point where you would be ventilator dependent. So the nerves that control the diaphragm, which is the big muscle that separates the abdomen from the chest, allows your lungs to go up and down. Those nerves all come out of C345 here in the neck. And so if you have an injury in C345, you can lose control of the diaphragm. Those patients then aren't able to breathe on their own, and those are the patients that can potentially end up being ventilator dependent. In terms of neurological exam as well, we always, if there is a disability in the neurological exam, then we will get a CT of the head to identify if there is a bleed or anything like that. Exposure. So this is like I was explaining about how patients need to be exposed. We need to turn them over, look at everything, get them completely undressed. So you want to inspect the back. When we inspect the back, we're feeling along the spine to see if there are any areas where we feel a step off, meaning that your normal alignment is now like this. If you have an injury to your vertebral bodies that's like this, you may have you may sever your spinal cord, and that can lead to paralysis. So that's part of what we feel whenever we turn the patient over to feel their back. Do we feel anything like that? That then is later confirmed on imaging. Additionally, we usually will do a rectal exam. If you're maintaining your rectal tone, that generally indicates that the spinal cord is intact. So that's one other way for us to check to see if we have a neurological or a disability of the spinal cord. Adjuncts. So once you get through the airway, breathing, circulation, disability, and exposure, you need to do a secondary survey. Now we're going to look for any missed injuries. Is there a broken arm? Is there a broken leg? Do they have abrasions? Are there injuries any other places? This is also where you, if you can speak to the patient, you get your history. What medical problems do they have? What medications do they take? What surgeries have they had? Are they on a blood thinner? All of those things you want to check. You complete your neurological exam from head to toe, checking every cranial nerve. And then at that point, if they still have issues and need to make a decision, is the patient going to be transferred? Are they going to be admitted here at Del Webb? What interventions do we need? All right, this slide is going to have some graphic pictures, so just be prepared, okay? So these are the key things that we need to look at initially that can injure a patient that will result in an untimely death. So the first one is airway. So this was a patient, not mine. This was a slide I took from one of my attendings at university. This is a patient that tried to commit suicide with a shotgun. They tried to put it here under their chin, but the shotgun was so long that when you lean forward to pull the trigger, the shotgun goes from here to here. And so they ended up shooting up through the anterior portion of the face, as opposed to through here to get to the brain. And so you see, obviously, the traumatic injury of the face. So how do you check to see if this person has an airway? You can't ask them their name, they can't speak to you, and so you don't know if the airway is intact. So you can see they have a tube here in the neck that's called a tracheostomy. That was most likely done emergently for that patient when they came into the trauma bay to obtain airway, so that way you know that you could ventilate the patient, get oxygen into their lungs. All right, this is that picture of that tension pneumothorax that I mentioned to you. All the black on that, what you'll see is the left side is air that should not be in the chest. And what you can hopefully see a little bit on the right side of the chest is that you can see, let me see if I can point it out for you. Oh, you don't see my pointer. But the trachea, which is your windpipe, should be normally right here in the midline. It's pushed completely over to the right, and it's almost at a right angle with how much pressure there's coming from the other chest. Additionally, that whole lung is also being pushed over to the right side of the chest. So the way to treat this is you put a tube or a needle directly into that left side to let all of that air escape. As that air escapes from the chest, then that lung and everything else will move back over into that space. But this, if it's not identified, and technically a tension pneumothorax should be identified by vital signs, not by x-ray. If you're identifying it on x-ray, you're probably too late. So that's something we always look for. Circulation. So this is a stab to the chest. So this knife was probably either in the heart or at the aorta. And so if you have a knife in the heart, then you're not getting any blood moving from the heart to the aorta to the rest of the body. So even though the patient may have a carotid pulse, they may not have a pulse distal, meaning lower in the abdomen, depending on where the blood can go. And then the last thing we'll talk about is devastating head injuries. So for example, this is a CT scan of the head. The part that you see, I guess it'll be your screen left, is disruption of the skull. So that white thick circle around is all the skull. And what you see on the screen left is that the skull has been disrupted. I believe this was from a gunshot. And so you can see brain matter has now also gone out past the edge of that skull. And so this is a devastating head injury which would obviously not be survivable. All right. Let's talk about one trauma patient. So this is a pretty typical trauma case that we get. And the management of this has changed over the course of the last 15 to 20 years probably. So I'll kind of go through this scenario and I'll explain what our thoughts are and what our priorities are. So MVC means motor vehicle collision. The patient was T-boned on the driver's side door. So they were hit on their side, on the left side, right? Because we're left-sided drivers in the US. The patient's awake and alert. Their heart rate is in the 120s. Normal is 60 to 100, okay? So 120 is elevated. Blood pressure is 90 over 50. It's a little low. Normal is 120 over 80, but with shock, trauma, you may expect the blood pressure to be a little low. And especially if patient is having hemorrhage, meaning they're bleeding, the blood pressure will be low as well. And then when you do your exam, they're tendered a palpation in the left abdomen and the left chest. So on the CT scan, I'll kind of point out a couple things to you. On the right side, the light gray that you see is the liver. Let's see, does this have a pointer? Oh, nice, okay. So this is the liver. This is the gallbladder. This is your spine. This is your spleen on the left side, okay? So this is a little reversed in terms of CT scans are always the opposite in terms of left and right, okay? Again, this is the right side of the abdomen even though it's the screen left. This is the left side of the abdomen even though it's the screen right. And this little wavy thing right here is actually the pancreas, so that you guys can see that. So what we're worried about is the patient had impact on the left side, they're tender on the left side, and we see this here in the spleen. The thing that's really important to recognize is this difference in the gray right here. This spot is a little bit brighter. Would you guys agree? So for us, the concern is that does this patient have a laceration or bleeding of the spleen? That's the number one thought that we would have coming in, given the mechanism of injury, MVC, T-bone to the left side, and then you see this on imaging. So this slide will kind of illustrate that further. So what we see is a splenic laceration, and we say that initially the patient is responsive to fluid and blood. So we give them fluid, we give them blood, their heart rate comes down to the 90s, and their blood pressure improves, 110/60. So what are our options? So if you were a trauma surgeon in 1985, this patient would have two options. One is we monitor them and trend their hemoglobin, or if they don't respond to blood and they don't respond to fluid, then they're going to the operating room for a big cut down their belly to get their spleen taken out emergently. Second scenario would be, say you give them blood, you give them fluid, and the heart rate doesn't get any better. The heart rate still stays in the 120s, it's creeping up, 130, 140, 150. Blood pressure continues to drop, so the patient is not responsive to blood. In the 80s, even probably early 90s, that would be emergency surgery. You're taking them to the operating room immediately, get their spleen out, take care of the bleeding. In probably the early 2000s, we had an increase in interventional radiology. So these are radiologists that use imaging to do procedures. How many of you have had a heart catheterization? Raise your hand. 1, 2, okay. Conceptually, do you guys understand the idea of when they need to look at the flow in your heart, they'll put a catheter into the wrist or into the groin to inject contrast to watch in real time how the flow is through the heart. And so say you're having a heart attack and they need to put a stent into one of the vessels in the heart, they can use that catheter to then pass a wire and pass a stent over that to then open up the vessel. What we found is that interventional radiology can actually do the opposite. There's one artery usually that goes to the spleen, and so they can gain access in the groin through the femoral artery, pass a wire all the way up to the splenic artery, and then occlude the splenic artery with either gel foam, coils, metal coils that literally block the blood flow to the spleen. And so if you block the blood flow to the organ, then this contrast that you see that is bleeding in the spleen should stop. So we've actually done the opposite of what you do in a heart attack. In a heart attack, you're trying to open the vessel. In this scenario, our goal is to close the vessel. So if you close that artery, then the bleeding should stop and the spleen itself will stop bleeding. So that's a non-operative option we have to manage patients who come in with a traumatic spleen injury. So when I was in residency and I was on the trauma service, I talked to my trauma attendings. They take out spleens, once a week when they were in residency. I didn't take out my first spleen for a trauma until I was a fourth-year resident. And so I went through probably almost 5 years. It was towards the end of my fourth year in residency. So from a trauma perspective, there are a lot of things that we can manage non-operatively now, whether it's with interventional radiology, whether it's with repeated imaging, and all of those factors reduce, hopefully, the morbidity to the patient if we can operate less, and that's the new goal. All right, so this next one is going to be my last slide before questions, but this next slide is pertinent to you guys. This is what I was alluding to earlier. So I was on call Christmas Eve. We had a patient that was brought in for an overturned golf cart. Patient was unresponsive in the field. Bystanders started CPR. When the EMS team showed up, they started ACLS, which is basically medical grade CPR. They had to give the patient epinephrine to get their pulse back. So think of adrenaline, something to kickstart your heart. They had to give him epinephrine 3 times. Once he got to the emergency room, we were all there because I was in-house, and they had gotten a pulse back, heart was breathing, but the heart was beating, but the patient was unresponsive, meaning that they were not conversing with us, they were not able to provide any history. So even though they had a pulse, there was nothing there neurologically. So in those situations, breathing tube goes in right away. We stabilize the patient and we discuss whether or not they're stable enough to go to CT. The other injury the patient had is he had an open fracture of his patella, which is your kneecap. So he had a big laceration across the front of his leg with exposed bone. We took him to CT and found that he had multiple injuries. He was transferred to a higher level of care at Banner Thunderbird, where he was managed for about 3 or 4 days. And when they found out all the injuries, the family ended up deciding to withdraw care, and the patient passed away peacefully. So this is a list of his injuries here on the left that we noticed just from overturning his golf cart. The biggest thing is, and I took out probably 4 or 5 injuries that were also listed here. But the first thing is cardiac arrest. So he basically stopped his heart heart was no longer beating, and EMS restarted it. The next thing he had was a left pneumothorax, meaning that there was a small amount of air in the left chest where it shouldn't be. He had bilateral pulmonary contusions, which means he had bruising of both lungs. He had rib fractures on the left side, 1 through 5 and 8. And then this is the key. What we saw at T7, T8 is he had a vertebral body fracture. So that idea that I was telling you about the spinal cord being potentially injured, he had that at T8. So T8 is just above your belly button, and so he was paralyzed basically from here down. He had a distal femur fracture, means the lower portion of the femur bone in the left leg was broken. The left kneecap was broken and it was open. He had a laceration to the skin of the knee. Rhabdomyolysis, this is basically the kidney shutting down. Anoxic brain injury, meaning that he had basically brain death due to no oxygen reaching the brain. He had encephalopathy, which basically means confusion. And then he had an acute left occipital lobe infarct, which means that he basically had a stroke on the left side. So this unfortunately was all from an overturned golf cart. He was not hit, at least from what we know, he was not hit. The police officers had some video, and what they could see, they didn't have video of the actual incident, but the after effects, and it looks like he most likely drove his cart, kind of went onto a curb, rolled it over. So, you know, we see some of these golf carts out on Grand, and every time I see it, I cringe a little bit. Something to think about. All right, that's all I have for you guys. Happy to take any questions, anything I can answer for you. Be happy to discuss. No, so I mean, obviously we don't know the sequence of events. The biggest thing that I left out was that his alcohol was about 270, and he was a big guy, 6'6", 350 pounds, and so for him to reach an alcohol level of that much would have been a lot to drink, and that's why I also asked how many of you have had some drinks before you get on that golf cart. So, something to keep in mind. Could he have had a heart attack first? Absolutely, we don't know. But with the way that we saw the tire tracks on the curb, you know, what came first, chicken or egg? Yeah. There's a question back there.
How important is your spleen?
So that's a great question. So the spleen is really important, especially when you're young, first few years of life. A lot of your immune system is based out of the spleen. But in terms of taking out spleens, we do it often, but not something that's regular. If we take out the spleen, then the biggest thing in terms of long-term immunity is that it provides immunity to 3 types of illnesses that you can get a vaccine for. One of them is a pneumococcal vaccine, one is a Neisseria vaccine, and one is it's not the flu, but it's the Hib, which is Haemophilus influenza, which is not to be confused with the flu. But if we have to take out the spleen, then we recommend those 3 vaccines to prevent any long-term risk of not having a spleen.
So it's dispensable, basically.
We can take it out, yes. Mm-hmm. Yes, we can take it out, but you have to get those vaccines if you have your spleen removed, or if we embolize the spleen, so meaning we have the radiologist block the blood flow to the spleen, because if the blood flow to the spleen is blocked, the spleen will die. And so then it's not effective, and so you would still need those vaccines. One more question in the back?
I have 2 questions.
Please.
One is, would you describe a little bit about the 4 levels of the trauma service?
Sure.
And then the second one is, if something happens to me, how do I decide whether I go to urgent care or a emergency room?
Sure. So I'll answer the second question first. So there's kind of a little bit of levels to that. So urgent care is something like, oh, hey, this is bothering me, but I feel fine. I don't feel palpitations. If I have the ability to check my blood pressure at home, my blood pressure is normal. Or like I got a splinter, I got a cut. I feel like I got the flu. Can I get a flu test? Emergency room is something like, oh, you know, I've been feeling bad for 2-3 days. I'm fatigued, I'm lethargic, I've had really high fevers, I'm uncomfortable, something hurts, something just isn't right. And then there's also the freestanding ERs that are around the area. There's like one that's on Prasada. There's a couple of the Dignity ones. The biggest thing with those is I would encourage you to avoid them, because if there is something significant that they find, they're just going to try to transfer you to the hospital, the main hospital, and we don't have beds. Yesterday, I got a consult from one of the freestanding ERs. They wanted to send a patient over for appendicitis. 18-year-old, healthy. The surgery would have taken 20 minutes, but we didn't have a bed. They called me at 10 o'clock in the morning, and by 4 p.m., they still could not tell me when the patient would get here. And so I called transfer services and I said, look, this is not appropriate. The patient needs to go somewhere where there's a bed available right away. The patient ended up having to get transferred all the way to Banner Desert in Mesa. And so one, that sucks because the patient went all the way across the valley, and it's just because we didn't have a bed. So when you go to these freestanding ERs and there is something that has to be intervened on, then they try to transfer you. So I would not go to those places, but again, not going to tell you what to do. And then in terms of the different levels of trauma, so it basically comes down to availability of acute services. So level 1 trauma centers, they have a trauma surgeon, trauma anesthesia, in-house 24 hours a day. So I go home, that's why I have a 30-minute response time. If I was a trauma attending down at Banner University, Banner Thunderbird, then there is someone that is a trauma surgeon in the hospital 24 hours a day, 7 days a week, and they can provide trauma services. Interventional radiology is available, neurosurgery is available, vascular surgery is available. All services are available at a moment's notice. Level 2 trauma centers, I don't actually know if we have any in the Banner system, but it's somewhere in between where the trauma surgeon doesn't have to be available or doesn't have to be in the hospital 24/7, but they have to be available. And generally it's a higher level of care where they have most services available. Here for a level 3 trauma, we don't have vascular surgery coverage 24/7. We don't have neurosurgery coverage 24/7. We do have interventional radiology, but they have an hour response time, and so if someone's critical, that's just not appropriate. And on top of that, the staff has to come in and everyone else has to come in. Level 4 is, I wouldn't even know how to define a level 4 because I haven't worked at one, but it's basically even less than we can offer. Okay. Other questions? Yes, ma'am.
Starts with level 1.
Level 1 is the highest, 2, 3, 4. Yes, ma'am.
How does AI and robotics enter into your profession now and in the future?
Sure. So from a robotics perspective, and I'll talk about it first on a general surgery side, then we can talk about it on a trauma side. So from a general surgery side, we do a ton of robotic surgery. I would say that 95% of our elective practice is robotic. So say you need your gallbladder out, you need your appendix out, you have a hernia in the groin, a hernia in the belly button. We do most of those robotically now. The AI portion of it is that the robotic systems are having AI built in, so they're doing machine learning, meaning that they are basically collecting the data of all the surgeons across the country and watching and categorizing and cataloging every movement we do while we're operating. So eventually, will that take away my job? I don't know if patients will consent to robots operating on them independently, but when I do robotic surgery, it's not like I'm at home in my pajamas operating on you. I'm in the operating room, I'm 5 feet away from you, and if there was an emergency and I needed to open you up right away, I'd be able to do that. Yeah. Oh, I'm sorry, from the trauma side. So they are trying to build up robotic trauma surgery. A few of my co-residents from when I graduated are trauma surgeons down at Banner University, and they're doing some of their trauma surgery emergently robotically. So one example I can give you, I had a patient who had, or I didn't have a patient, my colleague had a patient who had a diaphragmatic hernia. So that muscle that separates the chest from the lungs, the trauma was so bad from a car accident, they developed basically a hole in the diaphragm. And so when that happens, then your abdominal contents can go into the chest. So say you have a diaphragmatic injury on the right side, portions of the liver can go into the chest. And so my colleague was able to take that patient robotically and suture the hole in the diaphragm robotically as opposed to a big cut down the belly to close that area. Additionally, trying to repair that hernia in an open fashion is actually very difficult because it's a difficult area to reach with your hands. And so doing it robotically actually was easier for the surgeon, but also better for the patient in terms of recovery because they had 4 or 5 holes this big instead of a big cut down their belly. Other questions? Yes, ma'am.
Just a comment, personal experience. Went to one of these urgent care facilities, semi-hospital, and we got great care immediately. We didn't really have to wait, but the doctor was not there that we needed, the specialist. Something to consider if you have, if you're a patient, you have different specialty things that are going on health-wise. It may take a little longer at the emergency room. I'm not doing a commercial, but.
Yeah. I mean, our wait times, unfortunately, here in the ER are long. We're always full, which is good for business, but it sucks for patients. You can be in the ER for 8 to 12 hours. You may get a CT scan. You may not get a report back for 4 hours. Unfortunately, that's the reality of medicine. But part of that, it comes back to preventative care, right? If you have patients coming in because they need a refill for their diabetes medication, that's not an appropriate use of emergency room services. That's something that should be done through your primary care. I mean, urgent care probably isn't the place for that either, but that's a better stop than coming to the ER if you need your diabetes medication refill, right? But being established with a primary care physician, seeing that physician every 6 months or a year or whatever they recommend, doing your labs, taking your medications as expected, a lot of our long-term chronic issues, one, can be prevented by being healthy, eating, exercising, trying to avoid processed foods. But then also, as adverse as we are to taking tons and tons of pills every day, making sure that you're taking the medication regimens that your primary care is prescribed is really important in maintaining your overall health. And then doing what you can on your end to either get to a point where, hey, you know what, if I lose 20 pounds, my diabetes might get better, my high blood pressure might get better, and maybe I come off of those medications. Or if I can, change my diet to where my cholesterol comes down, then maybe I don't need to take a cholesterol pill every day. So that's where, like Nora was saying, part of it is taking ownership of your own healthcare, but also working in a collaborative effort with your physicians to get you to the goals that you have. Yes, ma'am.
Just a quick side note as far as you bringing up medications, and it's really important when you, as emergency physicians, that you have a correct history and how that can affect your job. Because if you don't have everything that's going on with that patient can't talk, it's really difficult for you guys to do your job.
100%. And so part of that is also seeing your physicians regularly, so that way your charts are updated, whether we have access to them or not. The other part sometimes that we see is that patients that don't know their history, there's not a family member available that knows the history. And so if there's a family member that can come with you or someone that's available by phone, that helps a lot. The other thing often that I suggest to patients when they come see me in the office for an elective procedure, bring someone with you who is going to help you remember things. Because if you're coming by yourself and I go through an entire risk-benefit conversation about taking out your gallbladder, and then your partner asks you, oh, hey, what'd the doc say? And then you say, oh, yeah, I just got to get my gallbladder out. Doesn't help, because part of what we do is also we talk about what the risks and benefits are. We talk about the expectations for recovery, what the first 5 to 10 days after surgery will be. And part of it is your first 24 to 48 hours after surgery, you're still going to be a little bit amnestic. You're going to have anesthesia on board. You may not be able to communicate those things to your partner. So being really involved in terms of having another person there that can help reiterate or remember what the expectations are for recovery is really important. And that's for all patients. I mean, I had a young 35-year-old male yesterday who had a hernia in the groin that needed to be repaired. I saw him in the office by himself. I gave him, every patient that I see gets pre-op instructions from me and post-op instructions at the time of consultation. So you get 2 separate pieces of paper that have everything outlined, written out word for word. And I always tell people, make sure you show it to whoever's going to take care of you after surgery, so that way they know what the expectations are. It's one of the first questions I ask when I see patients in pre-op, and he's like, I totally forgot. And so then I'm having the same conversation with the wife that I've had with him twice. Had the conversation with the wife before surgery, had that same conversation with the wife after surgery, where if they had read this piece of paper together, they would have a better understanding coming into the operating room. And to me, that's always surprising. It's like you're about to have a surgery, even if you think it's minor, all surgeries are surgeries regardless of how small or how big. And so developing that and being able to have that conversation with your partner and your spouse, I think, is really important. And it leads to better outcomes when the people that are involved in your postoperative care understand how the care should be undertaken. I think helps a lot. All right. Well, thank you all. I appreciate your time. We'll be happy to see you in our office anytime. We're right across the street. Thank you.
Thank you so much.
Absolutely.
That was great. I'm hoping many of you could relate to those stories as well as I did. My mother used to go to the cardiologist, and she didn't want anyone to go with her, and would come back, and I would say, well, what did he say? Nothing. He didn't say anything. And of course, she was hard of hearing. It was like, no, I'm sure he said something. No, it was really weird. He didn't say anything. So I so appreciate that key piece of advice. And I think we need to take it as older adults, because we're the ones who want to think that we're still young. But I think taking care of our health will allow us to live longer and healthier. So appreciate all of that. That was great. So thank you for joining us today. I want to tell you a couple of different things. One, you have a little survey on the table in front of you. This is really important to us. If this was of value to you, we'd like to know why. If there are subjects you would like to hear more about, like, should I play golf because my golf cart might crash? That's a really good question. We could do the research. But anything you're interested in the healthcare arena, we also bring in speakers around financial advice, wealth management, things like that. So
anything along those lines, it helps if you give us the ideas of what you're looking for, and then we can go find the right person to present on all of those. Also, I want to let you know that we record these and they're available on our website. So you can go back and look at other ones. Oftentimes, sort of like my mother at the doctor, you may have missed something and you want to hear it again. So we have been recording them for really about the past 2 years now, and you should be able to find, I would say, 6 to 10 of them on our website so that you can either pass them on to a colleague who isn't here in Arizona or wasn't able to attend, or watch them again yourself. On the Boswell campus, one of the things that is that we are raising money for specifically is their radiation and oncology center. And this is so critical because individuals now, if they need a certain kind of radiation therapy, which if you know anyone who's been through it, oftentimes you have to go 4 or 5 times a week at the same time for several. Well, if you need the right kind of radiation care, oftentimes you have to go to Mesa because we don't have the correct equipment and facilities here. So the goal is to take the facility, it's a separate building on the Boswell campus, expand that and get it to the equipment that it needs to offer that kind of treatment in our community. And I think I covered everything. So with that, thank you again for coming today. Usually there's leftover food and we're more than happy if you want to take it home with you. So go for it. Thanks for joining us.